Aha, there you are. Well, wait a minute. I see you. I'm on my page. Let's see if it pops up, if I can see us live. Emily's seeing us.
You can hear me too?
Yes, I can hear you. Emily can hear you. And I am asking for a comment. Hello?
Hey, Sherry, you better come too.
Okay, so we already have people saying hi. They're just Indra. There's like 5 people. Olivia's on. Hi, Olivia. Ashley's on. So welcome everybody. There is a significant delay, so I'm not seeing myself again live, but I don't know why the delay is a little wonky. So I'm not really seeing myself live, but I'm there. And welcome everyone to the October 2021 VBF Facebook Live. And we are bringing to you today one of my favorite experts. He is the past president of the American Academy of Pediatric Dermatology, also many decades at Johns Hopkins. And he's an expert in treating port wines, hemangiomas, and other pediatric vascular anomalies. Everybody can see us. They say they see us perfect. So say hello to everybody, Dr. Cohen.
Hi, guys. I don't mean to scare you.
You don't scare us, but there is this delay. So everybody's saying hi. I'm sure some of your patients are on here from the Netherlands are saying hi. Well, we are ready to take your questions. So Dr. Cohen is very familiar with treating port wine stains with lasers. He's familiar with topicals that some people are experimenting with lasers. He's familiar with hemangiomas and all the pediatric malformations and anomalies. So this is typically what happens, Dr. Cohen, since this is your first time. We've got 17 people now logging on, and they're going to start asking your questions, and the number will just keep growing. So hi, Angela and Karen and Jennifer and Ashley and Indra and all of you that are on, just please start asking your questions of Dr. Cohen. One of the things, there's a lot of new information out on lasers and topicals. Oh, we got our first question. Christy, hello, Christy, thank you. Are there any topicals to use for lightening a port wine stain other than the laser?
Okay, guys, that's something we discussed a little bit over the weekend. And actually, it's interesting. I just had a patient who sent a message asking for a refill on his topical medication. So we have played games a little bit with sirolimus, which is it does tend to suppress the growth of capillary vascular malformations. And we've also certainly used it systemically to treat and topically to treat lymphatic malformations. But maybe 4 or 5 years ago, we started a little off-label trial, unofficial trial, using it after pulse dye laser, when treating port wine stains, because there was some evidence that it would suppress the rebound phenomena, which many people do experience, at least subtly, after laser treatment, after they've had a response from a laser for treating their port wine stain. And I've actually had a couple of patients who, for any number of reasons, were not able to get laser treatment. And we've had at least, I would say we've had some response to using sirolimus topically, not orally. And again, you do have to be a little bit careful because there is a little bit of absorption when you put it on the skin topically, but certainly the level that you get into the bloodstream is incredibly low. We've actually looked at that a little bit informally. And again, I do think there is some data in the literature to show that particularly there's some series, not so much studies, but series showing that if you use it topically for a couple of weeks after you've had a laser treatment, that actually the response that you get from laser tends to be better and a bit more persistent because you don't get that regrowth phenomena that many people experience to a limited extent after they've had a laser treatment of their port wine stain.
Okay, thank you for that answer. I'm going to circle back to it, but I have quite a few questions coming in now. De Jong says, my daughter has a small one on her chest and we are putting timolol on it every day. This is a hemangioma, and now she wants to know, should we do laser and will that give us optimal results by combining timolol and laser?
That's a good question. My suspicion would be is that long-term with the timolol, you may achieve a response that's comparable to a combination. On the other hand, you may get a better response if you do laser and the timolol again, but I don't push people in that, because if you're having a good response now, and you're also going to see some spontaneous regression in hemangiomas as well. And certainly over the next year or two, you may see a dramatic response. Even if you weren't using the timolol, you may see it more quickly than if you weren't using the timolol. But even by itself, long-term, it's not unusual to get a significant regression without treatment. The timolol certainly helps. But again, I'm not pushing laser. But again, if you get to a point where lesions stabilize, you don't see further improvement, I certainly would consider it.
Okay, that's a good answer. And I know, past experts like Dr. Nelson does like to use the combo of laser and timolol, but that's with like early presenting hemangiomas, not once they get bulky. I don't know, maybe you have an opinion about that. Mom said this was a very small hemangioma.
I mean, a really small hemangioma, I'm not saying you shouldn't do laser, but you may see as good a response over time, even without timolol, but certainly timolol can speed up the process. I mean, if you get to a point where it's stabilized, you don't see further improvement, I certainly would consider, would consider some laser.
Okay, this is a great question from Elizabeth. She says, what are the options? I have a 6-year-old who has a chest hemangioma, and as an infant, they didn't recommend treatment. Now it has faded and decreased, but it's causing self-esteem issues. So obviously there's stuff left back, behind, which you and I both know there's always a residuum, like almost all the time if these are left untreated.
If there is little or no textural change and the primary change is one of color, then I think it'd be very reasonable to approach it with laser treatment. Now, the other thing you could do is, just as we were talking about in that other patient who I suspect was a lot younger, there's nothing against using one of the topical beta blockers at this point. So using something like topical timolol would not be unreasonable. You may see a significant response. Now, if there is a dramatic textural change in the skin, if you have loose, baggy skin, and the hemangioma has gone away, then at this point, it might be reasonable to talk to somebody in plastic surgery about revising the altered skin changes. Again, if the change is primarily color and the texture is normal or close to normal, you could certainly very safely experiment with timolol, and certainly laser would be a very safe option as well, or in combination of the two.
Thank you. That's a great answer. Amy wants to know, my baby has a hemangioma on his bottom near his anus. It has recently started ulcerating. Can it grow after 1 year of age? Not sure if he needs to go back on propranolol. Okay,
couple things. One is that depending upon the exact distribution, and you may have already had this done, it's not unreasonable to image to get an MR, magnetic resonance imaging of the lower back, the spine, the gastrointestinal tract, and the genital urinary tract, because again, depending upon the pattern here, there can sometimes be malformations associated with hemangiomas in your lumbar area, the lower back, the buttocks, the anal area, the genital area. So again, I don't know whether you had imaging done already. You may have, in which case it's not an issue. Secondly, is that I would expect you to see hopefully continued improvement. Interestingly, we did a little study looking at ulcerations, and we found that when we looked at all the kids who had hemangiomas, even the ones that were getting better while they were on propranolol, they were more likely, even though the risk was low, they were more likely to get an ulceration while they were on propranolol. So what I've sometimes done in children who were responding very well to propranolol, the lesions are shrinking in size, but they get an ulceration. Sometimes I will, for a short time, maybe a few weeks, stop the propranolol and use some oral steroids, or again, if it's a very small area of ulceration, I'll sometimes even try a topical steroid, because often when you do that, they, especially if it's small, topical, or if it's bigger, oral for a short time with steroids, oral steroids or topical steroids, you can see dramatic clearing the ulceration. But again, it sounds like if it's still getting better, you want to stay on treatment. If the treatment was stopped and there's still a significant amount of hemangioma left, I think it would be reasonable to talk with your pediatrician and someone in your neighborhood who has a special interest in managing hemangiomas, because it may be that a beta blocker, oral propranolol, something like that, again, if the lesion is stabilized but not improved enough, that you may see significant improvement at this point with that.
Great, that's a great answer. Next one. Hi, my 1-year-old daughter has two hemangiomas. She's been told she will require surgery. In Canada, they suggested to wait until 3 years old with hopes it may shrink and therefore will have a smaller scar. In the USA, we were recommended to get surgery ASAP, the earlier the better. She doesn't say where it is. I think that's always an issue, like the location. But anyways, that's her question, because they want her to wait till 3, she's 2, and you know, some of the consults maybe that she's had here have said this needs to be done now.
I mean, again, if it's not causing functional impairment, it's not unreasonable to wait a little bit. You may see further improvement. There may be some concern about a surgical procedure in a child under the age of 3 in terms of potential systemic side effects. So again, if it is causing major impairment, I mean, if it's blocking the eye or the airway or the ear or something like that, I probably wouldn't wait if it's stabilized and you know, you're not seeing further improvement. On the other hand, again, if it's not a major functional issue or psychosocial issue, because it's not you know, it's in a hidden area. Again, that's where the location is incredibly important. It wouldn't be unreasonable to wait a little bit, because even in a child this age, you can get away with waiting a little bit, and I think avoid the psychosocial impact. On the other hand, if that's a major issue in the next year or so, then maybe looking at potential for surgery a little sooner would be fine.
Okay, I think that's a good answer. Emily says her 2-year-old's port wine stain was misdiagnosed as a stork bite. We know that. Did the misdiagnosis affect her chances of full clearance? It's on her forehead between her eyebrows with no eye or eyebrow involvement. Again, I think it would be very important to see what it looks like, but assuming that it truly is a port wine stain, again, if you haven't seen any progression, if you haven't seen any increase in prominence, again, or any issues with, you know, skin breakdown, bleeding, that sort of thing, I'm not sure that you lose that much by waiting a little bit. Although, again, if you do see progression in any way, not so much enlargement, but you see other changes that may be an issue, then maybe earlier intervention would be appropriate. So it kind of, I don't know that you lose much, especially if it's a small lesion in this age group. On the other hand, again, if you see any signs of increased prominence, I think I'd probably think about intervening sooner rather than later. I mean, I think too, you know, a lot of them hear from our doctors about they want to laser them like right out of the neonate. And so their moms that don't do that, they feel like, did I miss a window of opportunity? And there's a lot of data that says earlier is better. But Dr. Nelson and Dr. Geronimus say maybe it is, but it doesn't matter what age, you'll still be able to get good clearance. So she shouldn't really worry. I mean, 2 to 3, like you say, maybe it'll get lighter and not dark.
Make it a little lighter, yeah. Now, listen, I don't think I'd wait till you're 10 or 12, because I think if you do that, again, it may not make much of a difference, but it's not unusual over longer periods of time to see increasing prominence of some of the vessels. It's not that they're growing, it's just that the vessels get a bit, the ones that are there may not increase in number, but they get a little chunkier. And so the response to treatment may not be as good as if you intervene earlier. But again, between age like 1 and 3, I'm not sure that you're going to see much of a difference, which is good.
Oh, and hi, a shout out from Ava Piles, one of our global ambassadors. Hi, Ava, and happy birthday. So she got a shout out during our Facebook Live for her birthday. So I think that was a very good answer, and a lot of parents ask about that and get nervous. Now, Ashley has a question. Taking into consideration the risk of general anesthesia at 1 year old versus 3, is it better to wait or proceed now? I've read about possible neurocognitive effects. So trying to figure out risk versus benefit of treating for a scalp hemangioma at 1 year or 3 years.
Well, again, the data here is a bit mixed, although I think we have increasing data to show that general anesthesia in children under the age of 3 may be associated with some neurocognitive issues. Now, I'm more concerned about children who are undergoing general anesthesia from the get-go, from shortly after birth, having multiple procedures, in the first couple of years of life. I think there, I don't have any question at all that there's some issues, and in fact, we were in the process of collecting some data, submitting a paper, but collecting some data. So next year, the next Vascular Birthmark Foundation clinic will actually be able to present some data to show that using topical anesthetics and maybe a little bit of oral sedation without general anesthesia can be incredibly effective, can minimize or get rid of the pain associated with treatment completely. And again, I think if it's done right, when you figure that most of the laser treatments that we're doing take, I think almost all of them take 3 minutes or less. In fact, many of them take 1.5 minutes or less, that a topical anesthetic, if used properly, even though it may be associated with some scariness for the kid, in terms of pain, we can minimize pain to almost zero if it's done properly. And I have to be honest with you, one of the things I always tell my colleagues is that, yeah, if you put a kid to sleep to give them a laser treatment when they're 1 year old, or 1 year old, or 14 or 15 months old, the pain associated with getting an IV put in it may take longer and be worse than the pain associated with using a very aggressive, very effective topical anesthetic and a procedure that takes less time than it takes for the anesthesiologist to put in the IV. So I would agree with you.
I agree with that, because these kids that keep going under general anesthesia, there's no other like disease other than our vascular anomalies that a baby would have to go under repeated anesthesias for something that's like superficial and on the skin. It's not like heart or, organ transplant or something like that. And I think the mindset now is we need to get them to realize that you want good pain management, but no general anesthesia, or as little as possible. I know
now, if you had an infantile hemangioma that was causing a lot of trouble, in other words, it was breaking down, it was bleeding, it was just a disaster. I don't think you're talking about multiple procedures. You're talking about a single procedure. In that setting, it would make sense to me for that child to be to go under anesthesia, to have it revised or excised or whatever. That's a different story. And you're not talking about repetitive treatments. I mean, maybe a second one, but we're not talking about it's not comparable to general anesthesia with multiple treatments, every 4 to 6 or 8 weeks in the newborn period, and extending it for a year or two, say for what many people unfortunately do, I think, with general anesthesia in kids with port wine stains, which I think we should consider avoiding that.
I agree. Karen asks a great question. She says, my 22-month-old granddaughter was born with what the pediatrician called a hemangioma on her back, round red spot, and one on the index finger. Is there any association with having AVMs elsewhere when you have hemangiomas? I have had 3 embolizations and a cradiotomy on my 3 durabrain fistulas myself. So I think the grandmother is looking to see if there's some mutation with her AVMs that are intracranial and her daughter's hemangiomas that are extracranial.
And the only thing I would ask is to make sure that you're comfortable with it, your physician is comfortable with the diagnosis. If in fact they're classic infantile angiomas, they're not likely to be associated with the same sort of vascular malformations that you're experiencing. And I think then we're okay. But again, it would be important to make sure that we're looking at a classic infantile angioma. There are other vascular lesions that you can have on your skin that could be a marker for, and potentially a genetic marker for vascular malformations and particularly arteriovenous malformations that can involve the central nervous system. So again, if the diagnosis is clear and there's no question that it's an infantile angioma, I think you can be comfortable. If it's not clear, then I think further evaluation would be appropriate.
I might have talked to her too, and she can email me at vbfpresident@gmail.com. I'd like to see pictures of the hemangiomas. Corinne Barnaga, our Director of Patient Advocacy and our PAN Director and our Chair, says, "Hi, Dr. Cohen." So she's in Seattle. She wants to say hi from Seattle. We have people, from all over the world that are watching now. Kathy from Florida. So Madeline, hello, Madeline. We're taking your questions. Here's one from Kristen. Do you treat adults? I live in Maryland. I'm 45 years old, female, with a vascular malformation of my lower lip, right inner cheek gums, and right side of my tongue. I had 2 sclerotherapy treatments with Dr. Mitchell and resulted in no lasting results. So would like to pursue laser.
I mean, in that setting, laser might be appropriate. We do treat adults. Once we get set up at our new practice, which is in the process of happening, hopefully within the next couple of months, although the administrators we're working with are very kind and very good, but they do take some time. In the meantime, with what you're describing, there may be, it may not be unreasonable to see somebody else who has more newer experience with some of the new approaches to interventional radiology. And I don't know if you've seen Dr. Mitchell. I don't know if you've ever seen Dr. Weiss. Dr. Weiss has kind of taken over since Dr. Mitchell retired, and he has a fair amount of experience with with both alcohol, which may be appropriate from the old days, but even in this setting, and he has a lot of experience with bleomycin, which I don't think Dr. Mitchell did at all, or not much of that. He has a lot of experience with. It may be appropriate. And he also works with one of the plastic surgeons who could help out. So I'm not saying that laser would be totally inappropriate, but from what you're describing, it may be reasonable to reapproach your lesions with interventional radiology and potentially vascular surgery as well.
Yeah, thank you for that. You gave her a good referral to Dr. Weiss, so that's good. Heather Bosquet wants to know, hi, what is known about IVF and Port wine stain? Our daughter was conceived through IVF and born with a Port wine stain on her arm. Is there a chance other embryos could be born with Port wine stains?
I mean, I think the chance is low and probably not more than what you'd see at random. I guess it probably has something to do with the source of the the IVF, genetics may play a role here to some extent. So the source may be an issue, although again, I think the risk is low.
I know I'm working on a survey that I'm going to be putting out to the general population for all vascular anomalies to collect and see if they've had any in vitro or anything like that. Because I'd like to see how many moms that have had any kind of assistance or hormone priming, IVF, or anything in vitro.
What's interesting about that is that there may be an increased risk of developing infantile hemangiomas. And there is some data to suggest that if you do things that disrupt the the process, and again, even minor disruptions may increase the risk of infantile hemangiomas. And there's some evidence that the cells in the amnion or other structures in the mom may actually pass into the baby and play a role in the formation of infantile hemangiomas.
Yeah, I mean, I've heard a little bit about that. It's just, not really well known, but also, when you're primed, you're given buttloads of estrogen, and we know that infantile hemangiomas are estrogen driven. We know that there's like the estrogen growth factors. At least I read that it was. So maybe, I don't know. Sajid Ali says, hi, I'm from Pakistan. I have a birthmark on my face. How can I remove it? We don't have anybody listed in Pakistan right now. We do have laser experts in Europe. Dr. Zaina Tunus is in Lebanon. But if anybody knows of any in Pakistan or any in like Southern India or, please let me know, because I'd like to be able to refer to them because we don't have any.
A photograph. I think she could send you a photograph too, so we know what we're dealing with. That would be helpful too.
Yep. Send some pictures to Dr. Cohen. Corinne or Emily has been posting his email. So if you scroll through the comments, you'll see his email. Amy says her daughter is almost 12 weeks old with a hemangioma on the forehead. We've been using timolol since she was 5 weeks, and it's been agreed she can't start propranolol due to it still growing. Would you say this is the best route to take? It doesn't make sense, but okay. I think she's saying they gave her topical, but they won't give her oral.
And understand that if it's still growing and if it's going to be a major issue, if it's left to grow, I would have a very low threshold to consider using the oral therapy.
Yeah, I agree. I don't know. Like we were talking about, different places in the world have different policies and procedures, which is annoying for me. I just wish everybody was on the same page, and I just wish they'd all treat appropriately. Emily Adams says, is inhalation only anesthesia still considered general? We just started PDL and our 2-year-old, they use inhalation with no IV. It takes less than 2 minutes. Our doctor does not do it on awake toddlers.
Here's my question, is that if it takes less than 2 minutes to do the procedure, I would certainly consider using an effective topical anesthetic, just because you still got to put this kid probably still has to have an IV, and even if they're not doing intravenous anesthesia, I don't know, and there still is probably some risk associated with systemic anesthetics. So, I mean, I would at least discuss with them the possibility of doing a procedure that takes less than 2 minutes with a topical anesthetic.
Yeah, I just was working with Dr. Coletti on this whole review he's doing of anesthesias used in children, and he said that the inhalation anesthesia is just as bad as any GA anesthesics, because I don't know what it is. I know some use nitrous oxide or whatever. I don't know what they're using, but he said it crosses the brain barrier. It makes sense to me. So for me, I know it's tough. Nobody wants to hold down a 2 or a 3-year-old. Most of the time they're stronger than their parents when they're mad. It's true. So Ariana said,
they could potentially use a topical anesthetic and a little bit of an oral sedative that doesn't put them that just kind of slows them down a little bit. Yeah. A little bit of diazepam or something like that. And that's, again, if I have somebody that's really aggressive kid, we'll give them a little bit of midazolam or something like that and use a topical anesthetic. And they usually don't remember anything, and we can restrain them for 1.5 minutes to do it.
That's good, enough time to get it done. So another question, Arietta says, my daughter is 5 years old. She underwent an MRI when she was 9 months with result unlikely malformation, superficial hemangioma on her right forehead with normal skin color. It seems like a soft, big mass. Multiple lymph nodes show at her right cheek too by the ultrasound. Any idea? We failed with propranolol. Sounds to me like the propranolol failed because it's not a hemangioma, even though it says unlikely vascular malformation, superficial hemangioma. She's 9 months. It sounds to me like it's not behaving like a hemangioma, but something else.
I'd probably get somebody to review the imaging to see if we can make a specific diagnosis based upon the imaging. I suspect you can, and if there's a way to get us, if you had to get a small biopsy so we know exactly what it is, that would be important. But again, I would review the imaging was done properly. They may be able to make a diagnosis based upon the imaging, review of the imaging as well.
Or maybe we can get her to send the imaging. She can contact me or you directly. Okay, we have a lot of people on. Lisa is saying, thank you for this session, Dr. Cohen and Dr. Linda. It's Lisa from Washington. They're just posting your email. Lots of people on. We're ready to take your questions. Hi, Amy. Hi, Luia, Frotto, Ariana, Madeline, Deb, and okay. So we're just waiting for the next question. Just want to make sure I didn't miss any. I don't think I did. Okay, well, while we're waiting for the next question, and you did say that, you're getting ready to settle into your new location, but you mentioned about you're hoping to have the new results to present at our meeting next year. And that's October 8th in California. We're planning on having a normal conference with the talks all in person and clinic in person, laser treatments, everything will be in person, more services, unless of course, between now and February when we have to make our decision, something happens. But for now, we'll be October 8th in California next year, and you'll be with us. And hopefully you'll be presenting your new findings. All right, so still waiting for some questions. I don't know if you know anything. I've been hearing some talk about some new lasers, new light sources. Are you hearing anything on these?
Not at this point. We're gonna probably meet with some of the laser guys in the next month or two and try to see what's going on. We've played games with NDAG and some of the things for other vascular malformations, Q-switch Alex for some pigmented lesions that have been associated with vascular malformations too. So there's a lot out there to play with, I think. And it's these things are really quite safe. And again, I think most of the time we can get really good anesthesia with topical agents. We've been playing with the topical agents for 20 years now, and we have a lot of patients, parents and patients who are very, very eager to use these things as opposed to general anesthesia if it's possible. Again, certainly if you have a larger lesion or require complex surgical intervention, that's totally different. We're talking about, again, brief procedures that can be done, like I say, usually within even some of the bigger lesions in 4 or 5 minutes or less, which again, I would say that like 95% of our lesion treatments are probably like a minute and a half. Sorry about that. So I think generally speaking, even some of the newer laser and some of the other approaches can be done relatively quickly hopefully without general anesthesia in the youngest patients.
Okay, Lucia has a question. Her daughter is 11 years old. She has a venous malformation. She's had multiple sclerotherapy treatments and is now having a glue embolization, then another procedure that I think is called a resection. This is because of mobility issues and constant pain with her knee joint. What can we expect from this surgery? Do you have any advice? So it sounds to me like she's got an overgrowth or KTS or an overgrowth of the leg, and I think the first line of treatment usually is sclerotherapy and or embolization. I don't know what your thoughts are. And I think she said they were going to do a resection. That must mean some debulking, right?
Well, again, I suspect that it's going to be a combination treatment. They're going to have, I bet they'll have both of the surgical folks in the operating room. It'll get glued, and then that'll be followed by the resection. I've seen people do, put little metal coils in. I've seen glue and that sort of thing. And I mean, those things can be put in by the interventional radiologist, and then the resection can be done by the plastics people. So again, if it hasn't responded or been persistently responding with interventional radiology, then it makes sense to get the surgical folks involved as well. So there's a good chance that you'll get not just get a response, but get a response that's persistent by having the collaboration of the two surgical folks.
That makes sense. So the next one is, I know this answer. So Amy's like, her baby is 6 months old, and she's been told that the hemangioma stopped growing at 6 months, but she's still seeing growth. He's now 1, and he went off of the propranolol. So you might want to address how long they can grow, and then also this rebounding that we're seeing a lot of when they come off of the propranolol.
Well, again, I think it is true that the most dramatic growth occurs in the first 4 to 6 months, but certainly you can see growth that extends beyond that. We've occasionally had children that have had some growth even beyond the first year of life. So our approach to management is to give them, to treat them with the beta blocker orally if they're having significant growth and the lesion poses a significant problem if left untreated. And then when we get to a point that we have a really good response, after 6 or 7 months of age, we might consider tapering off the drug, but we'll generally do a slow taper over a period of several months. And if we see some rebound, we're going to go back up on the drug. So again, I think that if you see a significant rebound, it makes sense to increase the dose back to the dose where you had a good response to treatment. So I don't think I would sit there and watch it grow, to be honest with you.
Yeah, I agree. So here's this is a very good one. Madison says her son has just had his second laser treatment on his port wine stain 2 weeks ago. I can see white circles from the treatment right above his eyebrows. Do you think the circles will fade in and look more smooth as he heals? So it sounds like a little hypopigmentation, right?
Yeah, well, again, it depends on what his natural skin color is like. What you may be seeing is just a more dramatic response in the areas that were treated with laser width. You have a dramatic decrease in the vessels there, and you still have some vessels around the outside, since you can overlap when you treat with the spots, but you don't want to overlap too much because it would increase your risk of getting an ulceration and maybe a scar. Now, if your child has darker skin type, you certainly can see some post-inflammatory decrease in pigmentation. That will usually go away over time, but it could take several months. It may even take more time than before you come back for your next treatment. But again, as long as there's no evidence of scarring, you would expect the normal pigment to return in time.
And I think that applies to all the parents that have asked that question. There's white spots, and Dr. Nelson, Dr. Geronimus, and now yourself say, yeah, that's true. The laser kind of sucked a little of your melanin out, but don't worry, in a couple months, it'll reanimate itself and be back to normal, correct?
Absolutely.
Okay, so Ann Camissa wants to know, is laser therapy helpful for ABM? I think maybe she says ABM. She wrote a B. I don't know what an ABM is, but I think she means ABM.
Yeah. So, again, there may be some use for laser to treat AVMs, especially the peripheral vessels. If the AVM has dramatic flow and it's significant, you're probably going to need to have interventional radiology involved. And again, often in an AVM setting, we'll work, in my experience, we've worked with the interventional radiologist. We go after some of the more superficial vessels that have less flow, but the interventional radiologist and perhaps even interventional radiology in combination with plastics or with vascular surgery have actually attacked the most dramatic lesions. And in fact, if interventional radiology and plastics go over the most dramatic lesions, there may be some more subtle lesions that are persistent closer to the surface, and those are lesions that may be very responsive to laser treatment.
Oh, so she qualified it? I think you might change your mind maybe. She was saying, I have a peripheral leg fast flow AVM that's innervated on the muscle, and I was diagnosed with Parks-Weber syndrome.
Yeah, I think in that setting, you're looking at potentially there may be some systemic treatments that target the genetic mutation associated with these, but I would think that this is where interventional radiology and plastics or surgery are going to be probably involved with dealing with that.
Well, what about, because she asked this next, about the drugs, and they are sirolimus, rapamycin, and those are chemotherapy agents. She wants to know about those for this.
Well, again, that's where I think in addition to having, you want to make sure that you check and see if there's a genetics person associated with your vascular anomalies group. And again, if you can identify a genetic mutation that would respond to systemic therapy, then that's certainly something to consider for treatment.
When you were, this is a side question, when you were at our conference this weekend, were you surprised at how many of the patients are misdiagnosed?
Oh, you're asking me?
Yeah.
Yes, I was. And not only that, but I was surprised at how many people were misdiagnosed when in fact the lesions, the vascular lesions on the surface of the skin told a very different story from what the patients were being treated for. So again, I'm just, I think that you can't always make a diagnosis based upon your examination of the skin lesions and even the deeper lesions that you might be able to feel. But I do think that I would bet that most of the time you can come up with a sort of a ballpark idea of what you're dealing with. And distinguishing certainly between capillary malformations of the very superficial small vessel vascular lesions and the deeper lesions, which may be lymphatic or venous or arterial. Again, I think you can at least separate the small lesions from the big lesions fairly easily, and then come up with specific answers based upon imaging, and if necessary, sometimes even a biopsy. But imaging in combination with your examination, you can often come up with a good ballpark idea of what you're dealing with. And I was surprised with how many were misdiagnosed.
Yeah, it's always a surprise to me. So, and again, with the AVMs, just to say, with Dr. Coletti at our meeting, he's talking a lot about finding out the mutation. And then when you find the mutation, there's a cocktail, a combo that works for the specific mutation. So that seems to be like where we're going to be going with AVMs that are extracranial. They're on the body or the face or the tongue or wherever. And I think it's exciting to know that, that could help.
The other thing too is that imaging is really very useful for the deeper lesions. And I would say that like 99% of the time, a good radiologist who's comfortable with looking at vascular lesions will be able to make a diagnosis, sometimes with an ultrasound, with a deeper ultrasound, but certainly with a magnetic MR imaging. But that you can certainly confirm a diagnosis that you have clinically with good imaging as well.
So DeYoung wants to know, what's the difference between a port wine stain and Cmtc?
Okay, so a port wine stain is a capillary, so very, very, very small vessels. They're very, very low flow lesions. They could fold in, it could be a little deeper in the skin, but generally speaking, they're really very, very superficial in the skin. They're very slow lesions, very slow flow lesions. Cmtc, cutis marmorata telangiectatica congenita. So when you look at the skin lesions with a port wine stain, not always, but usually they're relatively uniform, not completely, but relatively uniform. in CMTC, the lesions are what I would call sort of reticulated. You see this sort of like spider web like pattern. And the other thing is that and the vessels in that spider web like pattern tend to be bigger vessels. And in fact, most of the time, they're probably venous malformations or much larger capillary malformations than you're going to see with port wine stain. So again, clinically, just looking at them, you can very often distinguish. The other thing is that with classic CMTC in the newborn, not all, but a number of the spiderweb-like red or purple vascular lesions will have some atrophy. There'll be some linear dimpling of the skin. So you'll see a line where the skin is depressed in those areas. And that's actually absolutely classic for CMTC. So again, I think most of the time, it's pretty easy to distinguish between classic CMTC and a port wine stain.
Well, I also tell all the parents, I love that when a baby has a port wine stain and they go out in the cold, how it changes. And when a baby has CMTC, how it changes. And the way I've always explained it is that with CMTC, when they're in the heat, when they're hot, it like almost disappears, where with a port wine stain, it could get darker, you know, and I say to them, does it get lighter or darker with the cold? You know, and they say when the baby's hot or when it's hot outside, it disappears. And that's pretty good for like differentiating, in my opinion.
But again, you're going to see a lot at the end. If you look carefully with CMTC, you're going to get this, it's going to be a spider web-like pattern. And
right.
I would say that I don't think I've ever seen a classic CMTC that didn't have the those linear depressions in the skin. It's somewhere within the area if you look carefully. And the vessels tend to be much bigger in the areas in between the vessels. So in between the spider webs, it's often relatively clear.
So do those dimples favor a certain area?
No, they can be anywhere. I mean, anywhere the CMTC, you can have a CMTC anywhere, because it is associated with a genetic mutation, I'm sure. And it can, they are mosaic. So it could be anywhere on the skin surface. Most of the time, it's not hereditary. And sometimes it is. Most of the time, it's not. And it's localized to a specific area. And in that area where you have those spiderweb-like lesions, where the spider webs are darker in color, you'll appreciate some dimpling.
I have a question, like for families with face syndrome, everybody always thinks it has to just be on the face. But I've been reading a lot that basically it's not that it's the face, it's segmental. Do you have a comment on that for face syndrome patients?
Yeah, it's important to recognize that, well, most of them will have some facial involvement. There's no question about that. But there's a subset of them that may have the underside of the chin and the anterior neck or the upper chest involved. But they're going to be, and as you described it, they're going to be segmental. So often it'll come to the midline, or it'll be in a funny, sharply demarcated pattern that's a bit unusual. And it'll tend to involve the right side or the left side or both sides, but it'll often have those sharp lines of demarcations that say, in your head, you say, this is a segmental vascular malformation. Again, if it involves the face, the scalp, the neck, or the upper chest even, it's something that you should consider. Now, again, if it doesn't involve the face at all, the risk of having involvement of the brain is incredibly low. But if it involves the anterior neck and the upper chest, the risk of it involving the heart and the major vessels that come off the heart of the aorta goes up. If it involves the face of the upper, especially the upper face, the chance of having cardiac heart involvement is relatively low, but the risk of having central nervous system brain involvement is significantly high.
Wow, very interesting. Good to know. Good to know. Okay, so we are coming up on 13 minutes left. It's been a very busy Facebook Live session, but we still have time for a few more questions. These live videos, that we've done over 50 of them since January of 2017, have garnered about 150,000 views, and they're always on our YouTube channel for people to go back and look at anytime. So if you go to our website at birthmark.org and you'll see the little YouTube icon up at the top, you just click on it and then you'll have access to all of our videos that we've done from the beginning, and you can pick them by the syndrome and by the expert and hear the questions, because it's very valuable. I find it's very valuable. Let's see, there was one more. Oh, face syndrome. She wants to know what face syndrome is.
So these would be kids who have they have vascular lesions, usually port wine stain, capillary vascular malformation that involves the head and neck, or head or neck. It is associated with arteriovenous malformation. So they can have vascular blood vessel abnormalities depending upon the site in the brain. It can involve the eye. It can involve the ear. Again, if they don't involve the upper face, they involve the chin and the anterior neck and the upper chest. It's not unusual to have vascular malformations that involve the heart and the major vessels that come off of the heart. In fact, if it involves the neck and the chest, one of the things that we always look at is also the vessels that come off of the aorta down near the gastrointestinal tract. So if you look it up, the letter, if you go online and just take a peek, you'll see PHACES. You'll see that they have a P is for posterior falso anomaly. They can have arteriovenous malformations. They have cardiac malformations. They can have involvement of the eye. They can have, again, these other structural anomalies that we were describing. So it's just an abbreviation to remind people of what things to think about. And they can actually even have a little scar located over the mid chest or the lower mid chest, which is part of that too.
I think you meant to say a facial hemangioma. You said a facial port wine.
I'm sorry. Yeah, I meant facial hemangioma. Sorry about that. Yeah, so
Yeah.
these would be segmental hemangiomas. Yeah, so posterior fossa.
Yeah. And I want to say something about that, because we're learning more and more. And, we have a patient who's 20 years old that had face syndrome, and she started having endocrine problems. They never realized her hemangioma was so massive on her face that it literally crushed or pushed over her hypothalamus or thyroid. And she's now on medication to correct it. And then, we get patients in their 20s saying, hey, I have an AVM and I had face syndrome. My doctor says it's not related, but I've talked to you about this, and I think it should be its like own entity, face syndrome, because I think it's just a cluster of anomalies or something unusual. And also, per Dr. Bly, you only need a hemangioma plus one other thing to have face syndrome. You don't have to have the posterior fossa, the aortic defect, or any of that stuff. Eye involvement, that's always been described as abnormalities in the eye. So I think it's very interesting, and I think anybody who had a child with a massive facial or truncal segmented lesion, and they see these wonky things pop up in their health later on, they should be cognizant that it may be face syndrome, because we are seeing these patients now, since we've been around for 27 years, cycle back to us and say, my doctor says this isn't related, but you mentioned this, and it is related. So
it's important to evaluate these kids early on, because you want to pick up those anomalies. And again, if it involves the area, say above a segment above your eye, then I worry more about involvement of the brain. If it involves the area which includes the eye and the mid face, then I still worry about the brain, but different segment of the brain, I worry about the eye, I worry about the pituitary and other portions of the central nervous system. If it involves areas that are lower on the face and the neck, then you have to start thinking about hemangiomas in those areas associated with vascular anomalies of the aorta, the heart, and that sort of thing. So that's what I meant really, is that if you have lesions that involve the head and neck, you can have a posterior fossa malformation associated with hemangioma in the V1, the first segment.
Yeah, so I tell the parents with the children with face syndrome to keep a log of all health-related comorbidities, so they know like what's, in case they need to bring it to somebody's attention. So we're getting close to the finish. DeYoung said he's the one who asked about what is CMTC, and I guess maybe he must have been told that, but he said his daughter's has sharp demarcations on her abdomen, and her lesions look like marbles, but not like big spider web like you see with CMTC. He did say it disappears when she's warm. But do you think this is port wine or CMTC?
Well, again, it may be a venous malformation too, because that's again, she's had imaging. I think I would ask your pediatrician to review the imaging, just because they should be able to tell you what sorts of vessels are involved in the malformation with good imaging.
Yeah, she also said that her left leg is smaller than the right, and she has staining on it. But that can happen with CMTC as well.
Yeah, you can have that as, again, you can have classic CMTC with a overgrowth or undergrowth of one of the extremities. You could have a venous malformation that extends into the extremity. You may not have, so you could have classic CMTC, but associated with other markers for, venous malformation, that sort of thing.
So Madison says, my son's port wine stain is very light and is on his eyelid and part of his forehead. About how many treatments do you think will be necessary to get good clearance? We started at 3 months.
I mean, if it was a subtle port wine stain to begin with, my suspicion would be is that it would take a relatively small number of lesions to get a good response. I don't know. It could be as few as 2 or 3. It could require some more than that.
Right. I tell all the parents, there's no way to know unless once you have the first 2, you can get an idea of what the level or rate of clearance is going to be. And is it going to take 7 or 20 treatments or what? So no two, like snowflakes, no 2 port wine stains are alike. So she said, she said, the port wine stain on my son is very, very light. It's on his eyelid and forehead. I don't know. She said they started treatment at 3 months, and you can't guess until you have the treatments, right? And see like
Not respond.
the rate of clearance. Yeah. So everybody's thanking us. So I think that we're close to wrapping up. We'll grab one more question if it comes in, but we're 5 minutes before the end. Everybody's saying thank you. This is valuable information. Our free laser is coming up in December on the 4th in Texas. Another free laser in January with Dr. Duarte in Miami. It's on our website. I'm negotiating to get the free laser in Tucson, Arizona. We'll be announcing that. There'll be one in February in Italy, one in Washington, D.C., or the D.C. area in May for our month of awareness. So we're, currently just working on getting all these sessions, and maybe when you get in your new place, we can have an awareness day. You never know, right?
Absolutely.
Really super people that you work with. Corinne said, thank you for this very informative session. Everyone is thanking us. And we thank you all for tuning in. And Dr. Cohen, is there any pearls of wisdom that you would like to leave for our precious families that are dealing with so much with their children's children's birthmarks? And Tara, no, there is no limit to how many VBF free laser clinics you come to get free laser. We don't keep track. We're not going to keep track. If you're coming, it's because you need it. So you just keep coming, and we'll keep providing the free laser. So is there, again, Dr. Cohen, would you like to offer any?
I just think that it's important to keep in mind that sometimes things are not as obvious as you think, and it's important to, I think of vascular birthmarks as being evaluated sometimes requires input from dermatologists, vascular surgeon and interventional radiologist. And, you know, certainly in the last decade, we've taken advantage of the input from genetics as well, because all these new biologics that are out there, especially some of these chemotherapeutic agents, the genetic markers that we have found in some of the vascular malformations have been very similar. And there's some data already to show that the vascular malformations, the specific vascular malformation with specific genetic markers, may respond to some of these biologic agents. So I don't think we need to call them chemotherapeutic agents. I think we can call them genetic biologic agents, and think that, you know, understand that they may have applications not just with oncologic treatment, but also vascular malformations and other genetic markers.
Yep, I agree. And guess what? Next month, our next Facebook Live is with somebody very, very near and dear to Dr. Cohen. It is our November month where we will be promoting all things Sturge-Weber syndrome. So we have Dr. Ann Comey, who we will be doing our typical day after Thanksgiving live session with on Sturge-Weber. We have our new Sturge-Weber booklet. We have our port wine booklet, and I'm working on the hemangioma booklet, which Dr. Cohen will also be a part of. So thank
it's
you.
good to see that you'll have all the day after Thanksgiving, you'll have all the turkeys with you.
No, I always say it's the VBF Black Friday special. Right? So anyways, thank you, Dr. Cohen, for your time.
Pleasure.
And we look forward to seeing you again soon. Stay safe, everybody, and stay well.
Thank you, guys.
Thank you. Okay, I'm trying to find the end button and it's not here, Emily.
You turn me off here, sure.
Wait a second, we'll get you off of here. I'm just trying to find.
Okay. No, I'm sorry, I wasn't talking to you guys. You
Showing
turn the phone off. I turned it on.
Hold on, you're still on. What?
Pull that up for me. I can't do it on my fingers single.
Pull what up?
And then
Here.
exit up there.
Oh, there we go.
And